This case is related to acquired factor 10 deficiency in a patient with metastatic lung cancer. We were contacted by a respiratory registrar because the patient coagulation profile was abnormal, and this was abnormal for the first time. The patient previous investigations showed normal coagulation screen, and they were almost 5 years old. So when we repeat the coagulation screen, it was still deranged. PT was 20 seconds and APTT was 48 seconds. We requested for a mixing study from our coagulation lab, which does not show any correction. So we thought that there is some inhibitor going on in this patient. So we went straight to intrinsic and extrinsic coagulation study in the patient, which shows low factor 10 level. The rest of the factors were normal. Upon taking history from the patient, he denied any history of childhood bleeding. He had dental surgery as a child, but that were not complicated by bleeding. He does not remember any spontaneous bruising or any excessive bleeding from the wound. He had a tonsillectomy surgery as a child, but there were no bleeding complication. He has two brothers and two sisters. They were completely normal. Uh, his parents were not alive, but he does not mention any bleeding history in the parents as well. He has 4 children at the moment, which are all healthy and they do not have any bleeding disorder. 10 years ago, he has a cholecystectomy surgery that remained completely without any complication. There were no bleeding complication during the surgery or post surgery. The blood tests that were done in the pre-surgical assessment unit for cholecystectomy were also showing normal clotting profile. So we concluded that this case is acquired factor 10 deficiency causing deranged PT and APTT because of no previous history of bleeding, no family history of bleeding, and previous normal results. And the cause of this acquired factor 10 deficiency is most likely the metastatic lung cancer, which is secreting inhibitory protein uh, to prevent factor 10 from functioning. Now, this patient has a pleural effusion, and the respiratory team wanted to put a chest drain in it. So they wanted us to optimize the patient for chest drain. As you know, factor 10 concentrate is also available now in UK and in most of the Europe and USA as well. Or you can give PCC to the patient. So we prescribed tranexamic acid to the patient plus um, uh, PCC 20 international per kg. The patient factor 10 was 14, and we aim to keep it at 40 for the chest drain procedure, and to keep it at 40 when the chest drain is removed. The half-life of the factor 10 is around 35 to 40 hours. So we request the team to check the factor 10 level before removing the chest drain. If it is less than 20, then we will top up the patient again with PCC. But if the factor is around 40 or above 40, then it is safe to remove the chest drain for the patient. Acquired factor 10 deficiency can be due to malignancies, can be infections, can be amyloidosis, multiple myeloma. These are the few common causes of acquired factor 10. These patients are then followed in the tertiary centers with hemophilia facilities, and they are given bleeding disorder cards, and they are advised to contact the hemophilia center if they are planning any surgeries, cosmetic procedures, or they should inform the staff of other hospital if they are going on a trip or on a travel abroad. So this was a case of factor 10 deficiency, which is now stable and chest drain has been removed. Thank you.